بسم الله الرحمن الرحيم. وبه نتكلم عن Congenital heart disease. نبدأ classification of Congenital heart disease ونقسمها إلى مجموعتين: Cyanotic Congenital heart disease، ونقسمها تاني ل shunt lesion و obstructive lesion. shunt lesion اللي فيها increased pulmonary flow in the form of atrial septal defect, ventricular septal defect, beta ductus arteriosus and AV canal. الاسيانوتيك المجموعة التانية اللي هي الأوبستراكتيف ليجنز in the form of coarctation of the aorta, aortic stenosis, pulmonary stenosis. The other group is congenital cyanotic heart disease, further subdivided into group with decreased pulmonary flow in the form of fallotetralogy and tricuspid atresia, and mixed pulmonary blood flow in the form of transposition of the great arteries, total anomalous pulmonary venous return, truncus arteriosus, and hypoplastic left heart syndrome. نبدأ نشرح الشانت lesion in the form of VST, ASD, and beta. As regard VSD is an abnormal communication in the ventricular septum dividing the right ventricle and left ventricle, and VSD represents the most common congenital cardiac anomaly. About 15 to 25% of cases of all congenital disease. First of all, we should talk about the anatomy of the interventricular septum to divide the types of VECD. The anatomy of interventricular septum from the right ventricle. If we excise or open the right ventricle, we show the interventricular septum like a triangle in the form of what's called outlet septum in the upper part, which separates the infundibulum of the right ventricle and vestibule of the left ventricle. Outflow tract of both ventricles are separated by what's called outlet septum. And membranous septum, it is a circular membrane below the tricuspid valve, separate the upper part of both ventricles. And inlet septum, the most lower part, and the muscular or trabecular septum. And anatomy, we divide the VST into multiple types. The first is premembranous, and it represents about 80% of cases of VST. Muscular or trabecular, the next type in the instance. And outlet VST is divided into supracrystal VST outlet, infracrystal outlet VST, and lastly and least in the instance is the inlet VSD. Usually inlet VSD is not isolated, and it is a part of endocardial cushion defect. The defect is further subdivided according to the size into restrictive VST when the size is small, less than 1/2 of centimeter, with left to right shunt, occur due to higher left ventricular pressure than the right ventricular pressure, usually increased pulmonary blood flow and little pulmonary congestion and no heart failure. Non-restrictive VSD is large defect, more than 1 centimeter, and the pressure of both ventricles is equalized, and the direction and magnitude of the shunt depend on the ratio between the pulmonary and systemic circulation, and usually associated with heart failure and increased pulmonary artery. Clinical presentation of VSD according to the size of the defect and pulmonary blood flow and pressure. VSD, if it is a small VSD, it is asymptomatic and discovered accidentally during routine examination. Small defect or early in the first few days of life where the pulmonary pressure and resistance still high. Congested lung symptoms, the form of dyspnea, cough, repeated chest infection in case of large VSD associated with heart failure. Low cardiac output symptoms, interrupted feeding, and syncope. Large VSD, if not corrected, can lead to Eisenmenger syndrome. No cardiac output symptom in the form of small pulse pressure, pallor, cold extremities, excessive sweating, and heart failure occur. Precordial bulge, biventricular hypertrophy, pulmonary artery dilatation, accentuated second sounds due to pulmonary hypertension, left parasternal area harsh pan-systolic murmur heard all over the precordium due to the shunt across the VSD. Occasionally, when the shunt is big shunt, it causes functional mitral stenosis in the form of mid-diastolic murmur over the mitral area. Investigation for VSD is X-ray showing lung congestion, the cardiac hypertrophy in the form of biventricular hypertrophy and pulmonary lung. The next and the most important investigation is echocardiography, show the position, size of the defect, and the direction of the shunt by color flow mapping. Examination for the degree of volume overload in the left side and estimate the size of the defect, estimate the presence and the severity of aortic regurg, pressure gradient across the defect to determine if it is restrictive or non-restrictive VST. Cardiac catheterization for hemodynamic study of VST, and it is rarely needed except for closure or transcatheter closure. That are example of muscular VST, that an echocardiograph apical four-chamber view showing a muscular defect in the mid-septum. The next example is another muscular defect in the mid-septum, big muscular defect. And that's bicolor flow mapping showing turbulent flow from the left ventricle to the right ventricle, bicolor flow mapping showing muscular in the mid-septum. And the most rare type is the inlet VSD below the tricuspid valve. It's an example of perimembranous VSD that are. That defect is very rare defect, what's called Sherwood defect, and it is a shunt between the right atrium and the left ventricle due to a defect in the membranous septum, high membranous septum, which separates the part of the right atrium from the left ventricle, and the shunt occur from the left ventricle to the complication of VSD, recurrent chest infection, heart failure, infective endocarditis, acquired infundibular pulmonary stenosis, and rarely Eisenmenger syndrome in case of large defect, which leads to increased pulmonary blood flow, pulmonary congestion, pulmonary arterial vasoconstriction, increased pulmonary artery pressure, increased right side pressure up to reversal of the shunt, which leads to cyanosis. First, reversible vasoconstriction, then permanent sclerotic changes occur, and permanent vasoconstriction and the reversal of the shunt. Reversal of the shunt with cyanosis, occurrence of cyanosis is called Eisenmenger syndrome. Treatment, significant number of cases, about 30 to 50% of small defect close spontaneously, most frequently during the first or the second year of life. Small muscular VSDs are more likely to close up to 80% than membranous VSD up to 35%. Surgical correction for infants with large defect have repeated episodes of respiratory tract infection and heart failure despite optimal medical management. Some transcatheter closure of small defects can be done by transcatheter closure. The next example of shunt lesion is atrial septal defect, which is an abnormal communication between the two atria across the interatrial septum. It can occur in many portions of the atrial septum. Isolated atrial secundum ASD account for about 7% of all congenital heart defect, and it's more common. Types of atrial septal defect, 4 types according to the anatomy of the interatrial septum. Ostium secundum ASD, and is the most common. Ostium primum ASD, and rarely isolated. It is a part of endocardial cushion defect. Sinus venosus ASD, coronary sinus ASD. That is the anatomy of the interatrial septum when viewed from the right atrium. That is a defect in the middle part at the area of fossa ovalis is called ostium secundum ASD. The lowest part is called ostium primum ASD, and it is part of AV septal defect or common AV canal. And the most lower part is coronary sinus defect, sinus venosus defect, superior vena cava type in the upper part and inferior vena cava type of sinus venosus defect in the lower part of the interatrial septum. Etiology of ASD is sporadic and it occurs in spontaneous cases. Rarely it is a part of a syndrome like autosomal dominant inheritance does occur as a part of Holt-Oram syndrome, which is associated with hypoplasia or absent radius and first degree AV block like that picture. Holt-Oram syndrome. Hemodynamics depend on the size of the shunt and pulmonary vascular resistance. A large defect, considerable amount of oxygenated blood flow from the left to the right atrium to the right ventricle. Shunting of blood from the right atrium, from the left atrium to the right atrium during systole, right ventricular hypertrophy and dilatation. Despite the large pulmonary blood flow, pulmonary arterial pressure is usually normal because of the absence of high pressure communication between the pulmonary and systemic circulation. Pulmonary vascular resistance remains low throughout childhood, although it may begin to increase in adulthood and may eventually result in reversal of the shunt and the clinical cyanosis, which is also called Eisenmenger. Clinical picture may be asymptomatic or leads to congestive lung symptoms or complication like heart failure, which is rarely occurring in early childhood. Infective endocarditis is rare and Eisenmenger syndrome is also rare. Mild left-sided pericardial bulge due to hypertrophy may be seen in early childhood. The auscultatory finding in the form of white fixed splitting of the second sound, not affected by inspiration. No murmur related to the passage of blood in the shunt, but there is functional ejection systolic murmur over the pulmonary area, and rarely, if it is large shunt, lead to functional tricuspid murmur over the tricuspid. The form of X-ray show congested lung, right ventricular hypertrophy, and pulmonary outflow. Echocardiography is diagnostic and features of right ventricular volume overload can be seen in the form of flattening and abnormal motion of the ventricular septum. The location and the size of ASD can be seen. Lastly, cardiac catheterization can confirm the presence of the defect and directly measure the pulmonary artery pressure and compare pulmonary artery to systemic artery. That is an example of ostium primum ASD, apical foot chamber view by 2D echocardiogram, ostium primum ASD. That is an example of the left side ostium secundum ASD in the middle part of the interventricular septum, of the interatrial septum, in the middle part of the interatrial septum, and color flow mapping showing blood flowing from the left atrium to the right atrium by color flow. It's an example of contrast injection, what's called agitated saline. That is the arrow point to what's called negative contrast effect. Negative contrast effect, which is related to the shunt from the left atrium to the right atrium, showing the contrast filling the right side of the heart because it is injected through a vein. So it is present in the right side of the heart and disturbed by the shunt from the left atrium and showing what's called negative contrast treatment. If the ASD is small, many ASDs close spontaneously. Surgical repair of large defect usually after the first year of age and before school age. Mortality rate is rare and more in adulthood due to heart failure. Transcatheter closure in suitable ostium secundum ASDs and Blitzer device can be used in early childhood without surgical repair. And the last shunt we will discuss, which is called the patent ductus arteriosus. It is a normal communication between the aorta and pulmonary artery in the fetal life, essential for supply for the lung, blood flow to the lung, and it closes within 2 weeks after birth. BDA is defined as arterial communication between the inferior border of the aortic arch and the main pulmonary artery at the origin of the left pulmonary. The shunting of blood from the aorta to the pulmonary artery both in systole and diastole, both in systole, because the aortic pressure is about 120 above the 80, while the pulmonary artery pressure 25/10. So the shunt is continuous in systole and diastole, lead to volume overload of the left. Hemodynamics. There is left to right shunt lead to pulmonary congestion and increased pulmonary artery pressure. Increased blood passing to the left ventricle and left ventricular hypertrophy. Increased pulse pressure due to diastolic escape of blood from the aorta to the pulmonary artery. Clinical picture of patent ductus arteriosus. A small defect is usually asymptomatic and discovered accidentally. A large defect will result in heart failure, similar to that in infant with large VST with manifestation of congestive heart failure. Growth retardation, bounding of peripheral arterial pulse, a wide pulse pressure, apical impulse is prominent and heaving with displaced inferiorly and laterally. A systolic thrill may be felt in the second left. And by auscultation, there is accentuated pulmonary component of the second sound, and the characteristic murmur of the patent ductus arteriosus in the form of a continuous murmur in the left infraclavicular area, machinery inequality, and start just after the first sound and end in late diastole because it is continuous. Investigation for patent ductus arteriosus, X-ray chest, prominent pulmonary artery with increased pulmonary vascular marking. The left atrium and left ventricle are markedly enlarged with left ventricular configuration. Echocardiography is diagnostic for presence of patent ductus arteriosus. Left atrium and left ventricular hypertrophy are detected. The ductus can easily be visualized directly and its site can be estimated. Color Doppler demonstrates systolic and diastolic retrograde turbulent flow in the pulmonary. And that's an example, echocardiographic example that present of a PDA by 2T echo. And by color Doppler show continuous turbulence from the aorta to the pulmonary artery, filling it from below upward continuously in systole. And it is another example of continuous flow from the aorta to the pulmonary. The transcaster aortogram showing in the left side in the left panel there is flow from the aorta to the main pulmonary artery, contrast filling the pulmonary artery. After transcaster closure, there is no aortography show, no flow can be seen crossing from the aorta to the pulmonary artery. Transcaster catheterization in patient with atypical finding demonstrate increased pressure in the right ventricle and pulmonary artery, presence of oxygenated blood in the pulmonary artery confirmed of patent ductus. Treatment for neonate endomycin for uncomplicated PDA in preterm neonate. Surgical ligation secondary option for uncomplicated PDA in preterm infant and children. First option for complicated PDA. Transcaster closure for uncomplicated PDA. The next group of congenital heart disease, obstructive lesions in the form of pulmonary stenosis, aortic stenosis, and aortic coarctation. First, pulmonary stenosis. Types. What are the types of pulmonary stenosis? Pulmonary stenosis is divided into three major types: valvular pulmonary stenosis, supravalvular pulmonary stenosis, and subvalvular pulmonary stenosis. Valvular pulmonary stenosis is subdivided into dome-shaped type according to the shape of the pulmonary valve. Dome-shaped thin pliable valve with systolic doming with post-stenotic dilatation. Dysplastic pulmonary stenosis show pulmonary valve is thick, non-pliable, not associated with post-stenotic dilatation. Supravalvular pulmonary stenosis may be hourglass type, diaphragmatic type, or tubular type. Subvalvular pulmonary stenosis, infundibular اللي هو discrete fibrous narrowing, subinfundibular اللي هو hypertrophied subvalvular muscle is called double chambered right ventricle. Symptoms of clinical manifestation of pulmonary stenosis divided into symptoms and signs. The symptoms mainly low cardiac output symptoms, almost never presented with heart failure, but low cardiac output is the main symptoms in the form of fatigue, pre-syncope, syncope, cold extremities. That's the symptoms of low cardiac output. Signs of pulmonary stenosis: in the second left space there is systolic thrill, weak pulmonary component of the second sound, wide splitting of the second sound, harsh basal systolic murmur over the pulmonary. Severity of pulmonary stenosis according to the gradient measured by echo or by transcaster measurements. Mild pulmonary stenosis mean gradient أقل من 20. Moderate pulmonary stenosis mean gradient from 20 to 40 millimeter mercury. Severe pulmonary stenosis لو pressure gradient mean pressure gradient. That example of echocardiography of pulmonary stenosis, what's called dome-shaped type. On the left panel, the dome-shaped valve shows systolic doming, and on the left side, continuous wave plus show increased velocity and increased gradient across the pulmonary. This is another example of dysplastic type, which is thick without systolic doming and not associated with post-stenotic dilatation. Associated on the right panel, there is severe increased gradient across the pulmonary. That is another example of dysplastic valve. The valve is thick, restricted mobility, not associated with post-stenotic dilatation. That is example of infundibular or subvalvular pulmonary stenosis. The arrow is showing subvalvular pulmonary stenosis. Aortic stenosis. Types of aortic stenosis: valvular aortic stenosis, unicuspid aortic valve, tricuspid aortic valve, tricuspid, quadricuspid aortic valve, supravalvular aortic stenosis, and lastly subaortic stenosis. Subvalvular further subdivided into fixed subaortic stenosis, fixed in the form of discrete subaortic membrane or subaortic ridge, or diffuse subaortic stenosis, the form of tunnel subaortic stenosis or sigmoid septum, and finally dynamic subaortic stenosis, which is hypertrophic obstructive cardiomyopathy. Symptoms of aortic stenosis mainly low cardiac output symptoms in the form of pre-syncope, syncope, anginal pain, and the signs in the form of systolic thrill over the aortic area in the secondary space, weak aortic component of second sound, narrow splitting or reversed splitting of the second sound, harsh basal systolic murmur of aortic. That's an example to the echo of aortic stenosis showing systolic doming of the aorta. Another example showing systolic doming of bicuspid aorta. That's subaortic ridge or subaortic membrane seen by 2D echo, and show the right band show turbulent flow in the aorta due to subaortic membrane. Finally, we will talk about least common congenital heart. First of them is common AV canal. Common AV canal or endocardial cushion defect. Endocardial cushion defect may be partial or complete according to the AV valve. Partial, the form of ostium primum is D, cleft anterior mitral valve leaflet, dysplastic tricuspid valve, and both AV valves are inserted at the same level in the crest of the interventricular septum. Complete AV canal, ostium primum is D, single 5 leaflet AV valve, inlet VECD, and goes neck deformity, long outflow tract due to displacement of the aortic valve. AV septal defect, ostium primum ASD, inlet VECD, and common 5 leaflet AV valve showing left to right shunting across the AST and across the hemodynamics. There is left to right shunt at both atrial and ventricular level, leading to increased pulmonary blood flow and early onset pulmonary hypertension, increase the risk of Eisenmenger syndrome and early cyanosis. Mitral incompetence and the tricuspid incompetence lead to volume overload on both left and right. Clinical picture in the form of manifestation of heart failure. The liver is enlarged and the infant shows signs of heart failure and failure to thrive. Early onset of heart failure in the form of pulmonary congestion, low cardiac output symptoms, systemic congestive manifestation, transient episodes of cyanosis. Complete endocardial cushion defect is common in children with Down syndrome. Auscultatory findings produced by left to right shunt include a normal or accentuated first heart sound, wide fixed splitting of second heart sound, and pulmonary ejection systolic murmur, sometimes associated with click systolic. If there is large VSD component, second sound will be single second sound due to equalize the pressure in both ventricles. Additional apical hollow systolic murmur caused by mitral regurgitation. Investigation for AV septal defect, X-ray chest cardiomegaly is large of all cardiac chamber with severe pulmonary congestive. Echocardiography is diagnostic and characteristic. Chronic deformity of the left ventricular outflow tract due to displacement of the aortic valve, presence of associated lesions such as BDA or coarctation of the aorta. Doppler echo will demonstrate the size of the shunt and the direction of the shunt at the ventricular and atrial level. Cardiac catheterization is rarely required unless pulmonary vascular disease is suspected, such as in patients in whom the diagnosis has been delayed beyond early infancy, especially with Down syndrome. That's an example of apical four-chamber view in patients with complete AV canal. There is inlet VSD, ostium primum SD, and 5-leaflet AV. Another example in the stool, the 5-leaflet AV valve opened and AV septal defect is continuous with each other. The inlet VSD is continuous with the ostium primum SD. Another example is the stool, the inlet VSD is seen, inlet VSD and big ostium primum A. Another example of AV canal showing it in diastole and treatment. Because the risk of pulmonary vascular disease developing as early as 6 to 12 months of age, surgical intervention must be performed during infancy. Treatment of heart failure is mandatory if it aortic occlusion. Aortic occlusion is narrowing of the descending aorta around the level of the left subclavian artery, dilated aortic arch and great artery. Coarctation of the aorta, which is narrowing in the aorta, causing obstruction to the flow, usually below the origin of the left subclavian artery at the origin of the ductus. It's called postductal or juxtaductal. Infantile type is called preductal with arch hypoplasia. It is a severe form. The adult type is called isolated postductal. That's a mild form. Male to female ratio of aortic occlusion is 2 to 1. It may be a feature of Turner syndrome. It is a view picture of aortic occlusion. It is narrowing of the aorta. That's example of after this left subclavian artery postductal type of aortic. Hemodynamics of aortic occlusion. Aortic obstruction leads to high pressure in the proximal part of the aorta and aortic arch, leading to left ventricular hypertrophy and increased blood pressure in the upper part of the body and both upper limbs, and lower pressure in the distal part of the aorta and lower pressure in both. Collateral circulation develop between the upper and lower part of the aorta before the obstruction and below the obstruction. Severe coarctation, the presence of BDA lead to what's called differential cyanosis, cyanosis of the lower limb and non-cyanotic upper limb. Clinical picture of aortic coarctation, if it is mild, usually asymptomatic during infancy and childhood, heart failure in severe cases, manifestation of hypertension, especially headache, epistaxis, cerebral hemorrhage, and finally differential. Weak or absent femoral pulsation, prominent radial pulsation, radiofemoral delay. The femoral pulse is felt after the radial pulse. Blood pressure in the lower limb is lower than the upper limb. Left ventricular. By auscultation, there is continuous murmur best heard in the left infrascapular area, and the continuous murmur starts late after the first sound and continue through the second sound. A systolic ejection click or thrill in the suprasternal notch suggested bicuspid aortic valve, which is present 70% of cases of aortic. Murmur of mild aortic stenosis can be heard in the third right intercostal space. In older patients with well-developed collateral blood flow, systolic or continuous murmur may be heard over the left and right sides of the chest laterally and neonate or infant with more severe form of coarctation may have signs of lower body hypoperfusion, acidosis, severe heart failure. On physical examination, the heart is large. Systolic murmur is heard along the left sternal border and loud second sound. These signs may be delayed days or weeks until after closure of the ductus arteriosus. If detected before ductal closure, patient may exhibit differential cyanosis best demonstrated by simultaneous oximetry of the upper and lower. Investigation for aortic coarctation X-ray is very important. Show left ventricular hypertrophy and rib notching due to presence of collateral pressing on the ribs, enlarged left subclavian artery in the left superior mid is present. Echocardiography is diagnostic for aortic coarctation. The segment of coarctation can be visualized directly by 2D echo. Associated anomaly of the mitral and the aortic valve can be also demonstrated. Continuous Doppler can measure the gradient across the coarctation, and color flow mapping show the degree of turbulence across the obstructed area. CT and MRI, valuable non-invasive tool for evaluation of coarctation when echo is equivocal. Cardiac cath with selective left ventricular angiography and aortography is usually not required surgery. As an example, 2D echo example for presence of aortic coarctation, we observe there is dilatation of the aortic arch and narrowing of the descending aorta at the isthmus. Post-ductal aortic coarctation was dilated left subclavian artery. That is dilated left subclavian with color flow mapping showing turbulent blood flow in the descending aorta due to presence of. By continuous with the blood, the pressure gradient and severity of coarctation can be assessed. That CT angiography of the aorta showing dilatation of the ascending aorta and the aortic arch with dilated left subclavian and very narrow post-ductal aortic coarctation. That's an example of MRI showing dilated aortic ascending aorta and dilated left subclavian artery and post-ductal severe coarctation. Digital subtraction angiography. Digital subtraction shows the dilated collateral between the upper and lower part of aortic coarctation and shows the aortic segment, the narrow aortic segment. Treatment of aortic coarctation in neonate with severe aortic coarctation, prostaglandin E1 infusion, surgical repair once the diagnosis has been confirmed and the patient is stabilized from heart. Older infant with heart failure with good perfusion, anti-failure measure, antihypertensive treatment, surgical intervention. If it is suitable for balloon angioplasty or aortic stenting, Finally, we will talk about fallot tetralogy, component of fallot tetralogy, malalignment VSD, subvalvular infundibular pulmonary stenosis, overloading of the aorta, and right ventricle. The four structural defects of fallot tetralogy due to rightward deviation of the outlet septum to the subinfundibulum lead to narrowing of the outflow tract and the presence of perimembranous VSD and overriding of the. It is an echo example of fallot tetralogy showing the aorta overriding the crest of the interventricular septum, showing right ventricular hypertrophy and the big malalignment VSD. Thank you.